Okay, as promised, we're returning back to a combining form we covered just a few slides back, leuko, which means white. And we want to give you a couple of additional words about leuko so that you have them for the semester. So we have a condition called leukocytosis, similar to erythrocytosis, except in leukocytosis, it is an abnormal increase in the number of white blood cells, primarily an indication of infection. So we would often see this on a CBC report, a complete blood count. And if it comes back with elevated leukocytes, in other words, leukocytosis, then we're going to start looking for infection. That's usually the key indicator, one of the key indicators. Leukopenia is an abnormal decrease in the number of white blood cells. So just like erythropenia, everything needs to remain in balance. If there's too much or too little of basically anything in the human body, some type of complication can arise. And our last color that we're going to cover in this chapter, actually in this semester, is melano, which means black. You heard me mention earlier melanin. This is a pigment that gives color to hair and skin. It's produced by something called a melanocyte, and once again, cell that produces melanin, or melanin, depending on who's pronouncing the word. So these cells produce the type of pigment that is going to give color to your skin and to your hair. The lack of melanin is albinism, as we discussed earlier, but if you have normal levels, it simply determines that color. So if you have brown hair, black hair, blonde hair, as well as your skin, if it's light, dark, and all those shades, that's kind of determined by what type of melanin that's produced within the melanocytes in your body. Now we're going to take you on a brief tour through clinical medicine and give you some abbreviations. We're going to deviate from skin for a little bit and just kind of give you an outline of clinical medicine. So hypothetically, you've been informed by your insurance company, and we're going to assume that they have sent you a name of a doctor and said, this is your new primary care physician. And so you're going to go visit that person. So you call the office to make an appointment, and they're likely going to ask you some questions and then send you some forms to fill out before you come see the doctor. That primary form is going to be the history. Here's where we ask your basic demographic information, including name. We want to get your age, where you live, what you do for a living. Immediately, we start getting information about who you are just in that information. And then we start asking more specific questions. Have you ever had cancer? How many alcoholic beverages do you drink? Have you ever used recreational drugs? Do you smoke? Do you have a family history of breast cancer in your mother or prostate cancer in your father? We ask questions about the grandparents. The history, abbreviated HX, is a way for the physician to kind of put together the story of who you are as a patient. History and physical, which is abbreviated H&P, is kind of a follow-up to that. So let's say you fill out that history form, you make the date to go see the doctor. When you show up, they're going to have a history and physical. So they're going to look at your history. They're going to take their own history by asking you questions. And then they're likely to perform some type of physical examination. That is at the bottom here, physical exam. PE is the abbreviation for that. So the history and physical is referring to a form. The physical examination is referring to the procedure of them kind of looking you over and making notes about you and figuring out who you are. So let's say you've gone through that whole system. Now you're showing up to see the doctor for the physical exam. You've filled out the forms. The doctor now has forms they're going to fill out, which in our modern age are more likely going to be on the laptop than they are written, although you'll still see some doctors that are going to handwrite these forms. And so the first thing they're going to do when they do the physical after the basics is they're going to do a review of systems, an ROS. This is a system-by-system review of the body functions performed by the physician in the process of taking a history from the patient. They're going to look at your circulatory system, your nervous system, your respiratory system, digestive system, skeletal system, muscular system. And we're also going to assess your skin when you come in, because it's one of the things that we look at that seems to give us a lot of information about you. So as a medical assistant, when I'm putting you in the chair and taking the blood pressure and I'm asking you questions, I'm also doing assessments. I'm seeing kind of where you are. I'm also, just kind of evaluating. One of the things I help evaluate is the cardiovascular system by doing blood pressure, take your temperature, all that kind of stuff. So that's our review of systems. It's just seeing, is there any cause or reason for concern? Is there any disease state we have to deal with? So you go through that whole system and you leave the doctor's office and you call back a couple of weeks later and you have what's called a chief complaint. This is the primary symptom that a patient states as the reason for seeking medical care. So let's say you've gone through that whole thing, you had your physical. A week or so later or a month later, you notice there's a mark on your arm you didn't notice before, what we would call a lesion. And lesion is a generic term that we use for skin to describe anything we don't know, anything that we don't know what it is yet. So you see something that was on your arm for the last couple of days, but you don't recall that ever being there. You have no wart, no freckle. So you call the doctor's office and you say, I have this thing appeared on my arm, I'd like to be seen. Well, in clinical medicine, we call that the chief complaint, and that is abbreviated CC. So that's what we put on the schedule. Patient complains of skin lesion. For instance, doctor comes in that day, they look at their schedule, they see your name, they see the chief complaint, they know why they're going to see you. So they come in the room right away and say, well, show me what it is. I want to see what this thing looks like. And they take a look at it and say, I don't know what that is. We're going to have to take a specimen here and find out. So they're going to do a biopsy, and that's abbreviated BX. A biopsy is a removal of a small piece of tissue from the body for microscopic examination. So you see an illustration of a liver biopsy here. I've actually been present for one of those before, and I didn't realize that the person taking the specimen was also the pathologist. And they took the specimen from the patient, went straight to the microscope, and began working up that specimen. In the case of the story I'm telling you, however, you've come in with a lesion, doctor looks, I don't know. They use a punch biopsy, which is a small round instrument that removes a small piece of the tissue, and they're going to send it off to pathology. They're going to give it to me as a medical assistant. I label it, package it along with the order form, and the orders from the doctor send it off to our pathologist because they want to know, is this specimen malignant or is it benign? You've heard me use these terms already. So we're going to go ahead and apply them right now. Malignant means cancerous or life-threatening. Benign means non-cancerous or non-life-threatening. So we need to determine, first of all, is this something that just happened? And you will find as you get older, skin lesions pop up that you never saw before, and they're completely benign. If you have moles in your body, which most of us do, sometimes they appear out of nowhere. If you're concerned, always get a medical opinion. Usually they end up being malignant, or pardon me, benign, excuse me, usually end up being benign. Occasionally, however, we do find a malignancy, and of course we want to address that right away because it is life-threatening. And one of our jobs in healthcare, and one of the things those of you seeking careers in healthcare are set up to do is try to help people be as healthy as they can, and some of you are going to be engaged directly in life-saving procedures. The result that we get back from the pathologist is going to give us a diagnosis and a prognosis, likely. The diagnosis, which means knowing through, if you remember the suffix gnosis means knowing through, and dia means knowing rather, and dia means through. Put in together, it means knowing through. It's abbreviated DX. It's the identification of a disease or condition. So what do we know through? Well, we have all kinds of evidence. We have objective and subjective. Objective is subjective, you've told us what's going on. Objective, we've taken measurements of things, in this case a biopsy, but it might be an EKG for the heart or a pulmonary test if it's the lungs we're looking at. Once the diagnosis is applied, via experience, they can apply a prognosis, which means knowing before. So this is the predicted outcome of a disease. If you have a melanoma and you treat it versus not treating it, that makes a big difference. If you have liver cancer, you decide to treat it or not treat it, the prognosis would change. If you do treatment, we would say, well, if you do this, this is likely what will happen. If you don't treat it, this is likely what will happen. So the diagnosis tells us what it is. The prognosis tells us what the predicted outcome might be. And you just heard me mention this term, and I've kind of been building towards it. Melanoma, meaning black tumor. This is a dark, pigmented, malignant tumor of the melanocytes. It's attributed to intense exposure to sunlight, commonly begins with a dark, pigmented mole, and it can metastasize widely throughout your body. We're going to address the term metastasize in just a moment. I just want to give you a few heads up about melanoma. So, frequent skin exposure to sunlight without any protection at all can be an indicator for the onset of melanoma. The places we see that more often is on the scalp, and that's one of the more dangerous ones, and it appears on the scalp beneath the hair, so it doesn't really jump out at you and you don't see it. I personally know of multiple cases where people had melanoma that started on the scalp and wasn't found until it was really a huge problem. The other places you'll see is at the top of your cheekbones. We call that the orbits, the lower orbits of the eyes, the tops and the backs of the ears and that area around the ears, tops of the shoulders, tip of the nose, top of the top lip, top of the bottom lip, chin, toes, just about anything that you can think of. If you imagine yourself standing in sunlight, anything the sunlight's hitting could produce a melanoma. Now, I'm going to pause this for a moment. I'm going to change screens, and when I come back, I'm going to give you a little bit of diagnostic information about melanoma. Now, I've changed screens here. I'm on a website that is showing you the A, B, C, D, and E of melanoma. I don't know how this is going to look on your screen, so I am going to scroll just a little bit to make sure that we can get everything in the screen. And so I'm going to lower this just a little bit. And so the A, B, C, D, E's of melanoma. I'm giving you this information so you can do self-assessments. None of these things isolated into themselves absolutely mean it's melanoma. In other words, just because it appears 1, 2, or maybe 3 of these things are happening doesn't mean it's melanoma. But any of these could be concerning. So if you see them on yourself or your patients, I just want you to be aware of them. The A is for asymmetry. One half is unlike the other half. As you can see here, there's one, the shape isn't the same. So a symmetrical circle would be perfectly round. Asymmetry means not perfectly matched. Borders on B, an irregular scalloped or poorly defined border might be the indicator of a melanoma. The color. These types of skin tumors will have multiple different colors in the same spot. You see tan, black, sometimes white, red, or even blue. That's probably the stronger indicator. I would say A and C are much stronger for positive melanoma. So if you ever have a mole or a lesion that appears that changes color, that's something you should go see your doctor about, probably sooner than later. The diameter, of course, is important. Melanomas are usually bigger than a pencil eraser, so about 6 millimeters when they're diagnosed, but they can also be smaller. They can be very tiny. And the last one is evolving or evolution. A melanoma will often change in size, shape, or color over time, sometimes within the same day. You'll see a small spot that got bigger. Now it's getting more sort of erratic margins and things are starting to look sort of abnormal. That can happen in the course of a week or so, sometimes less, sometimes more. If you want to research this further, I would suggest going online and looking for, searching out sites for melanoma. And there are great diagrams to show you exactly how you can do melanoma self-exams. It's important for yourself if you have lots of unprotected sun exposure. Might also help you out in your future career, depending on what aspect of medicine you're working in. However, I just want to be cautious with this. Just because you see abnormal moles on yourself or a family member or a patient does not mean it's melanoma. If it has one of the characteristics I've just listed here, it could be suspicious for it, and it never hurts to ask. I would rather ask a question and a doctor, which has personally happened to me, laugh at me and say, no, that's not melanoma. So I have actually had that experience as a patient. I was convinced, and they looked at it and he went, oh my gosh, no, that's not even close. Big sigh of relief. So it doesn't hurt. I'd rather have a doctor laugh at me than to have them look at me and say, you should have got this checked 6 months ago. So that's just a little personal anecdote from my life. I'm going to go ahead and pause the recording here. And when I come back, we're going to continue on with our next segment because we've reached our 15-minute limit right now. So I hope this is useful information to you. I'll be back in a moment with some more medical terminology.